I specialized or showed a main interest rather in congenital cytomegalovirus infection because as the most frequent congenital infection and the most commonly responsible for fetal damage before these babies are born, and this is the most common question we ask when we see features of infection on an ultrasound examination. So it takes a lot of our time in prenatal diagnosis and fetal medicine to think infection, and while thinking infection, think CMV, because this is the most prevalent. France can be unfortunately characterized as a very laid back and more paternalistic country regarding cytomegalovirus, because France does not promote any screening, and it does actually promote not to screen, which is making decisions for the women instead of informing them. Although not by law, but some recommendations, they recommend against screening, but they claim that women could be aware of CMV. They don't give any incentive for that, and therefore women should know that if they want, they can get the screening done. The problem with that is that the doctors will probably know less than the women about the condition, and doctors, when they know less than the women about a condition, they end up having and showing very protective attitudes, and that will not help. So the first step towards screening is to educate doctors. We do as much as we can, probably not enough, and that's one of our goals. Ideal world, the vaccine will be there, and therefore the issue with primary infection will be solved, providing women become conscious that vaccine is not a bad thing. And at the moment throughout Europe and probably worldwide, there's a huge disarray against vaccination, and people don't realize how lucky they are when there is a vaccine available. So in an ideal world, the vaccine against CMV will stop primary infection. That might not get the burden of non-primary infection off our shoulders, but that would solve the problem at least by half. Future research, actually current research, should address the emergency. The emergency is what can we do for a sick fetus? And therefore, I think we should move forward with intrauterine treatment of infected fetuses, starting with symptomatic ones. We have tools to assess the prognosis of an infected fetus. We can use so far not the best antiviral drug, probably the safest, but now are coming new antiviral drugs. They should be on the market within 6 months, and we need to coordinate our efforts to convince the drug companies that pregnancy is a field that needs to be addressed and not a field that should be avoided, because they do avoid pregnancy because of all the risk, supplementary risk carried for a drug to be associated with problems in pregnancy.